Good morning, everyone. Today it's my great pleasure to introduce Dr. Frédéric Gilbert from the University of Tasmania. He's going to present his talk on the ethics of implantable brain-computer interfaces, and he's going to discuss the question, what could phenomenologically go wrong? So I'm very happy to host this talk today. I remind you is within the cycle on phenomenology of bioethics hosted by California State University's Bay. And the floor is all yours. So thank you for being here.
Thank you very much again for the invitation. Yeah, so I wasn't sure how I should start that presentation, so I thought I would just take a piece of or depiction of brain-computer interfaces and try to use that as a a way to come with the topic. So anybody knows who is that protagonist on the screen? Perhaps most of you are probably very too young to know that protagonist. It's a famous Japanese manga. Name is Granzinger. So in French was Goldorak. Or did I see someone putting an answer there? Oh, well, no. Well, thanks for me. Yeah, it is awesome. Anyway, the reason why I'm putting that robot in front of us is because his mission was to defend the planet Earth. And in one of the season 2 episodes, sorry, I'm losing control of my mouse. You can see the prince in yellow meeting and being reunited with the princess. They were, separated by a universe, and finally they can be together. And on the first night, the two lovers, something are together, but something wrong is wrong. The princess starts to scream and cry. And suddenly she attacks violently the prince and with an iron bar, smash his head, try to kill him. Again, these are Japanese manga. They are very violent. That was back in the 70s, that being said. And at the last second, someone saves the life of the prince and the doctor. The doctor is the professor with the mustache. Scanned the brain of the princess, and they found out that she was implanted by the sworn enemy of the prince, the Vega Force. And the professor explained to the princess that, well, don't feel guilty because you were manipulated by the brain device, right? So you're not responsible, you're not accountable because the brain device has forced you to try to kill the prince, right? So I thought it was interesting just to bring that tiny reflection from the 70s to sort of have a perception of the urban mythology surrounding implantable brain-computer interfaces. And now what I would like to do is to look at how we can understand the phenomenology of being implanted with an implantable brain-computer interfaces. And that's the purpose here of my talk. So this mythology that brain-computer interface might impair our ability to think or might manipulate us is spread across different layers of a society. And there's a lot of literature describing prospective patients, or patients that will likely receive a brain device named deep brain stimulation. And when we ask them about their fear, their expectation, many of them describe a sort of a fear of the cyborgs. And for instance, they describe their concept of being afraid of becoming a creation of a sort of a self-transcending human-machine hybrids. And they're a bit concerned that if they are implanted in their brain, they will become that way. Or Klein and colleagues also describe patient a fear that they will be distorted of their true self in a way. And I would like to analyze it a bit further the underlying idea that if we cyborg human control or decision, it might lead to some catastrophic effect. That being said, I'm not a transhumanist. I'm not a post-humanist. I'm not in favor of enhancement. I don't even have a smartphone, to tell you the truth. So I'm just sort of interested again in the phenomenology of being implanted, of the subjective experience of being implanted here. Right, a way to push away this fear about cyborgs, people implanted with brain-computer interface, is to look at a classic and monumental work such as the one of Haraway about cyborgs and her Cyborg manifesto. Sorry, I'm just trying to move my face because it's taking part of my, yeah. So she described that, cyborgs or cyborgology is basically the rejection of classic or traditional boundaries, and we should not distinguish as clearly, what distinguishes us from machine or animals, and as sort of separating us. And there's a little bit of, if you identified as a cyborg, therefore, you might be cyborg yourself. But I think it's philosophically a bit not very robust. It's a bit actually flawed to think that identify as such, by definition, will allow us to understand what it means to be a cyborg. And just to jump on that premise, I would like to use the work of Gillian Weiss, and where she distinguished between cyborgs and triborgs. So, and I'm just going to quote her and read her because she's although she's also a poet, and I think she very captured faithfully the essence of distinction, what we should distinguish between cyborg and triborg, in order to understand again the subjective feeling of being implanted. So she goes that way. The existence of triborgs as a category, again, I have to move my own face because I can't see the screen. Yeah, as a category of person is so obvious that once I point it out, you will immediately recognize a dozen triborgs you know or whose work you have read. It is possible that you are a triborg. Most cyborgs are disabled people who interface with technology. We depend on a computer for all major bodily functions. So Visa is herself a disabled person. So the triborgs is a non-disabled person who has no fundamental interfaces. The triborgs is a counterfeit cyborg. The triborgs try to integrate with technology through the latest products or innovation. The triborgs adopt the pose of a cyborg, but no matter how hard they try, the triborg remain a pretender. Hence the word they try, so they are triborg. They are not cyborg per se. So then that's how basically she finished her attack on Haraway manifesto, and she said that in the manifesto you read, everybody is cyborg. The cyborgs are our ontology. It gives us our politics. But as she conclude, Haraway is a triborg. She's never been a cyborg. The reason why, because she's not disabled and she has no interface. And I think I would like to start my analysis from that point. So if we look at the interface and the fact that disability might be caused by cognitive impairments or neurological impairment, as such, we are in a position to understand again the phenomenology of being implanted. So now, what are brain-computer interfaces? There are many technologies falling under the umbrella of brain-computer interfaces. They are called closed-loop device, open-loop device, adaptive device, and so on. There's many of them. So what I would try to define tonight, and I mean this morning, is, well, let's define brain-computer interface as a system capable of capturing or identifying specific neuronal activities or brain activity, and to convert that into a signal or a therapeutic outcome, right? So it capture, the most common example is a paralyzed person with their brain implanted to an interface, and through the interface, the system read the brain activity and convert that into a specific movement or signal, et cetera, et cetera. Right, so also the reason why we need to look at the impact or the potential impact of brain-computer interfaces on personality, for instance, agency, autonomy, identity of self. It's because when we look at the media and how media are depicting brain-computer interface, we realize that we are into a highly positive description, and we're not in a position to understand potential harm. So we did a study analyzing from the first time that the word brain-computer interface was thrown in use media, that was back in '93, up until January 2018, and we analyzed about 4,000 articles, and we saw that 76, almost 77% of the time, the media were depicting positively brain-computer interface with almost no mention to ethics or risk of harm. So in comparison, only 2.7% were only mentioned risk of being implanted with these devices. And again, if you put that in contrast with the fact that they boast about the fact that brain-computer interface will enhance humanity, and also the fact that 70% of them, they talk about the future, they speculate about the future rather than talking about what we can actually do with the technology. I'm just going to skip this one just to show the rate. And in a further analysis with Christopher Pham, we demonstrated the more an article will be positive, the likely it will be speculative and ignore ethics, actually. So, and in that paper, we actually use Harry Frankfurt bullshit argument to say that most of the time newspapers are bullshitting about the brain-computer interfaces because they only target potential future application and rather looking at concrete aspect, trying to convince the reader rather than bringing actually the truth out of the media. Right, so that being said, there's a real necessity to look into what could be the phenomenological impact on a personality or agency, because we don't know much about it. So it's not the only aspect, but I will focus on that today. But I just want to list here quickly some issue associated with testing brain-computer interfaces, and I should say experimental trial testing brain-computer interfaces, because there are only few devices that are being regulated by the FDA, for instance. Most of the rest are just experimental trial that we're testing on vulnerable patients. So do very quickly. So first element is the inclusion, exclusion. So when you test these devices on animal, at what point you have enough data or evidence to jump in humans? So you have to include some patients. So for instance, would someone with a trajectory of mental illness be allowed to participate? If not, why not? And so because sometimes some of these devices are specifically targeting depressive symptom or people with OCD, etc. So it's a bit complex. Also, the very notion of informed consent, we discussed a lot about how we have to be clear and explain everything prior implanting something in the brain. But the fact that many of these patients have to get explanted, it's not very clear how it could happen. So there's a lot of risk associated, not only again risk of harm in terms of the physiognomy, but also psychological risk of harm. Obsolescence. So we know that most of the patient implanted with these devices, for instance, with the UTA array, that would last 3 years. So in terms of the experimental trial, we know that in 3 years' time, they have to be explanted. And that's just they're losing their opportunity to be treated in the future because the technology will be redundant and obsolescent. So they have to be removed. Think about your phone. Every 3 or perhaps 2 years, you need to change your phone. So imagine if you have a computer in your head, it has to be changed very often. And when you remove something out of this neuronal tissue, it damages and you lose your opportunity to get a better treatment in the future. Concern about privacy, confidentiality, hacking. So imagine you have a computer 24 hours per day pumping out your neuronal signal. It's just not, this, we call it noise, but it's a bit more sophisticated. Potentially you could have, a neurological signature of, Parkinson, Alzheimer's diseases, or other marker like this. So it does pump out a lot of data out of your brain. Some are talking about, the fact that soon, some AI system are capable of predicting of what actually you're thinking about. We're not thinking about things very complex, but if you saw an images, you know exactly which image you're thinking about. So also think about how it may download somehow some of your inner thought. We're not there yet, but it's a possibility. So so where I would like to look again is to how can we anticipate the potential impact or the putative impact of brain-computer interfaces on the idea of what we call PIAAS, personality, identity, agency, autonomy, authenticity, and self. PIAAS. And a way to do that is to look at a previous generation of brain implant. They call open loop, mostly known under the name of deep brain stimulation. So they are sort of automated system. That's an example here of an open loop where the system monitors the brain. And when it detects a specific neuronal activity, it will discharge electricity. But these devices, deep brain stimulation, you need to manually switch on or off the electricity and the stimulation. As such, the patient receives the effect. So an example which quite actually is analogous to my Japanese manga. This is a very famous, perhaps some of you know that case, was published in '99. This is a French patient, one of the first patients ever to be implanted with deep brain stimulation. I would like you to invite to look at the chronology. So you can see letter A, B, C, and D. And you can see through that chronology, there's 90-second difference, right? So from the moment that she seems to be stable, then you see that she's anxious, then she's crying, and at the end she's laughing. And that was induced to a simple manual stimulation of her brain activity. And on the right, you can actually read. Still have to move again my own picture. There it is. So when they were asking the patient between A and B what happened, because she was starting to be anxious, she replied, "I no longer wish to live." And she wasn't experiencing that before. It was somehow induced by this stimulation. She said, "I no longer wish to live, to see anything, hear anything, feel anything." So when asked why she was crying and if she felt pain, she responded, "No, I'm fed up with my life. So I'm fed up with life. I have enough. I don't want to live anymore. I'm disgusted with life. Everything is useless, always feeling worthless. I'm scared in this world, etc., etc." So again, that go through 90 seconds. They repeated the experiment 3 times, two other times, sorry, so 3 times. And after 90 seconds, so the depressive symptoms were gone. And for the next 5 minutes, she was laughing, being very friendly with the researcher, even playing with the tie of one of the researcher. And when asked, "Do you remember what happened?" She did remember what happened, but couldn't really explain. I think we are going on something where you see the interface, you see a phenomenology induced by a stimulation here. Let's get a little bit further. We also ran some research, qualitative research with a patient implanted with deep brain stimulation. All of patients had a Parkinson's disease, and I will just skip the detail, but if you are interested, it's an open access study entitled "I Miss Being Me, the Phenomenological Effects of Deep Brain Stimulation." And what we have found is that DBS may induce a sort of self-estrangement or post-operative self-estrangement that seems to be characterized by some qualitative or common qualitative elements, such as loss of control. And this is an explanation of what we're trying to capture here. So the patient 4 describes, so after being implanted and stimulated, the patient declared, "I can't be the real me anymore. I can't pretend. I feel like I am who I am now, but it's not the me that went into the surgery that time. My family say they grieve for the old me. They say they don't recognize me." So the interviewer asked, "And why? And in what way they don't recognize you?" Patient 4 replied, "That I am so impulsive and seems to change my mind all the time." Right. So this is what we would call a deteriorative self-estrangement, where there's a loss of control. But we also notice other element of restorative self-estrangement, where you have individuals that will act out of character, but in a sort of a distorted way. So here are the 2 examples. The first example is the lady that right after being stimulated, they twisted the stimulation, she decided that she wanted to see her husband, and she knew that walking toward her husband would take days. But despite that, understanding that, she decided that she wanted to do it. Her neighbor stopped her, and when asked how can you explain what happened? She replied, oh God, I wasn't me. I knew I wasn't me. And there was nothing I could do about it. I knew what it was. I knew the deep brain stimulation had been turned up that day. Unlike the drugs that creep on you and you don't know what is happening, with DBS, I knew what it was. So it's quite interesting here. There's a shift in the blame. The blaming is put on the technology rather than on the decision making leading to the action of walking toward the husband. Again, here it seems that there is a shift in the responsibility and accountability according to the first experience or subjective experience of the patient. And here, aligning with the previous case of a restorative self-estrangement, this lady after stimulation declared, I felt I was 15 years younger. And this is what we meant by distortive or, distorted perception of self-estrangement. So I felt that I was 15 years younger after the operation. I felt so strong and confident I could do anything. I felt so good, I tried to move the pool table and I ruptured the disc in my back. I blame DBS for that because I felt so good. I did something that I couldn't have done when I was 21, and I don't know why I thought I could do it when I was 54. I was in a wheelchair for 2 months. Here again, there's a shift in blaming the technology where the patients put less accountability and responsibility on their action and decision. Okay, so this is a first look at on open loop system, and now let's look at the current one that are tested in human called closed loop devices, where patients are in the loop. It means that the patient has more autonomy. It's not just a system stimulating your brain by manual modification. Here you have an intelligent device capable of reading constantly your brain and adapting accordingly, right? And as such, the patient may decide to do something, and it gives more autonomy, if you will. So these are brand new devices, and we are looking into the regulation and how we can protect patient in an experimental trial, but also through the market. So let's look actually at some of the first one tested in human to look at the phenomenology. Oh, the reason why we need to do that, it's because AI or AI implants are the future of the technology. So AI system in implants are a synonym of predictable technology. So the system constantly monitor and scan the brain in order to predict what will happen to the brain. And as such, it's a very predictive and powerful tool. And there's more and more of pathologies that are being treated as something that we want to predict. So think about addictions, aggressiveness, various cases of sexual aggression. So if you have an individual that has their brain constantly monitored by a device that can predict that outcome, it will be extremely useful, although I doubt it will work, but it would be useful in terms of a criminal perspective. You could potentially allow someone to be released out of a prison. Think about if you could, treat addictive patients because they would know their urge, or they could avoid the urge, or you think about you could implanted pedophiles, for instance, et cetera, et cetera. So that's why we think, it's the future of the technology, predicting the brain activity ahead of time, right? And the reason why it's so effective, it has been tested in human for the first time here in Australia. Actually, if you are interested by that study, which was initially published in the Lancet, and our study was picked up 2 times by Nature. And today, actually a few hours ago, the New Yorker has published a big reporting piece on that trial. I think it's 5,000 words. The title is Do Brain Implant Change Your Identity? And they largely talk about our research and also by interviewing some of the patient involved. So again, how it works, the device is trained, it's personally trying to understand the brain activity and predict epileptic seizure, right? And as such, then alert the patient, keep the patient in the loop, and the patient decide what to do with the circumstances. Right. So I'll just jump the methodology. So what we found, most patients have stable interpretation of or self-understanding, everything's fine, but we find very two extreme cases throughout the spectrum. On the left hand side, you have the radical distress, the sense of the loss of the self, experiencing harm induced by the technology. And on the other spectrum, you have a sort of symbiotic fusion with the technology that has increased the sense of control, a sense of the self. So I'm just going to look in through that. So patient 6 is a lady that had epileptic seizure, chronic epileptic seizure for more than 50 years. You have to think about when you have chronic epilepsy, it means that you can't drive your car, you can't really walk on the sidewalk because you might just fall in the street. You can swim. You always need someone around because you don't know when a seizure will happen. So when she was implanted, she was capable of controlling and managing her epileptic seizure. So it was a radical modification of herself. And all of a sudden, all the seizures were under control. So it has, again, a spectacular impact on her self-understanding and control. So how she described the technology. So the BCI was like an alien at first. You grow gradually into it and get used to it. So it then become a part of every day. It become part of you because this is what it did. It was me. It became me. With the device, I found myself. It changed who that person was. Then I found myself changing, growing, I suppose. It changed my confidence. It changed my abilities. With the device, I felt I could do anything I wanted to do. Nothing could stop me. So again, we're back on these sort of distorted restorative estrangement, self-estrangement. But in contrast, patient 3 had a very, very incompatible experience. And again, I have to stress the therapeutic endpoint was successful. So in other terms, the device were working, were effective, even with patient 3, but the psychological reaction or the phenomenological reaction to that effective device was quite dramatic, and you will see. So patient 3 described, I had epileptic seizures since I was 16. I just kind of pretended that I didn't really, that it didn't really exist. I didn't really see myself as an epileptic person. So she was implanted in her early 20s, right? So she only had epilepsy for 4 years. The BCI made me feel like I was just sick all the time. It made me feel like I was different to everyone else. I didn't want it to show anyone that I had it. And I was like, I only have epilepsy. I felt so weird all the time. Before it, I only felt strange having the seizure. The BCI made me feel like I had no control. So I didn't have control over what I was going to do. I got really depressed. I had been depressed as before. I'd been very depressed, and I knew what depression was. I knew what depression felt like. I knew I'm getting depression. I remember how depression felt, and I could very much exactly feel the same. Sorry, yeah, feel very much exactly the same. So and here we can see that there's a radical rupture that seems to characterize a self-estranged effect of the technology rather than a restorative one. But again, the interesting element is that in both cases, the technology was effective and working properly. Right, so the first conclusion, so can I, what time is it now, Susie? Can someone tell me what time is it now?
Sure, 30 minutes.
All right, so, and I'm supposed to talk 30 minutes, right?
Yeah, so you're
All right,
perfect.
so I'm just going to close. I have two conclusions then. Okay,
Yeah,
we'll
take your
finish.
time. It's very
We'll finish with that. So what I would like to stress again, this is a quick presentation for all that data, obviously, and I'm very happy to hear your interpretation and feedbacks. So again, I hope I will not repeat myself too much, but I think we have observed that if we want to tackle and grasp the phenomenology of being implanted with brain-computer interfaces or implantable brain-computer interfaces, I think we can see there's a psychological side effect, potential psychological side effect that seems to sit on two clusters. The first one is the feeling of loss of control. That is associated with a radical loss in self-understanding. I've seen with patient 3, but also we're seeing also with DBS. I mean, these are open loop, but still. And the other cluster is this distorted perception or fusional perception where someone seems to merge and have this symbiotic relationship with the technology. And again, the first one will be a deteriorative sense of the self that will lead to a certain feeling of powerlessness. And that's being observed with DBS patients that sort of lose control. They become so impulsive. Some of them actually attempt suicide. Some are successful in committing suicide after that. And the other one is the larger restorative sense of the self that boost their self-esteem, their confidence. But the tragedy is that because these are experimental devices, they have to be explanted. And patient 6 actually was traumatized, and actually that's why you should read the New Yorker article is about her being explanted, and we talk about how it has actually impacted her negatively. And the last part is that well, I mentioned that. So we found evidence that even if you have a very effective technology, even if you have Elon Musk, Neuralink, very expensive, very fancy, beautiful, even if it worked, it doesn't mean that it would correlate with the well-being of the patient. And this is quite crucial to understand. It's also known that the burden of normality that's being observed in other pathologies. All right, last slide. There's funding opportunity for PhD in University of Tasmania. Unfortunately, at the moment, nobody can fly in Australia, but keep an eye, or if you have any interest, just drop me a line. I'll be happy to guide you further. But in the meanwhile, thank you very much for your attention, and happy to answer your questions. Sorry, I wasn't really looking at the discussion. So I guess, Susie, can you manage?
Okay.
Yeah, thank you very much.
Thank you so much. Thank you. Really interesting. We have already one question lining up. I saw that Katie was asking the question while you were talking. If you can talk, Katie, go ahead. Otherwise, I will.
Oh yeah, I was just curious who actually implants these devices. Like, is it neurosurgeons or is it companies that do this?
Yeah, so because let's use the example of NeuroVista, so the trial that I was talking. So yeah, those who implant are neurosurgeons, but it's done by a team. So you need the actual clinician that's refer, enroll, and the funding is actually come from the industry. So in the NeuroVista, again, it was a very successful trial from a medical perspective, but the company ran out of money. So they were bankrupt. And that's why they had to explant the patient. And this is how I describe the case. It's the first Blade Runner phenomenon that we've seen is because patient 6 refused and resisted. She wanted to have the device. Imagine you have 50 years, you have chronic epilepsy, and with the device, it's gone. So your life is completely changed. You're a de novo person, but this device is a property of a company. So that's what there's a Blade Runner aspect where they try to run away, but the company is chasing her. So, but we had this weird situation where obviously the police, they didn't call the police to arrest her and remove forcibly the thing, but there's a lot of element. We've seen that also with DBS where people are psychologically forced to remove the device, and more should be done actually. But yeah, that's a sad story, but it's not the first time that the patient are being forced to have the device removed.
Thank you so much. I appreciate that.
Thanks.
We have two more questions. So Andrew asked, what year was this experiment conducted?
So the NeuroVista, so the trial finished in 2013 and started sometime in 2009. So it's a sort of an old trial, but it was because it was a not a happy ending. We didn't hear much about it, so we had to trace. It was a hard work to get from the back door, but there's similar technologies now working in the United States. NeuroPace, for instance, it's a technology that instead of letting the patient in the loop, the patient are kept out of the loop. So the device read their brain and stimulate the brain with electricity when they predict epilepsy. And again, it's just again, BCI are complex but quite simple. Read brain data, convert that into a signal, and then you can do anything with it. So yeah.
That's very interesting. Thank you. Joseph asks, what do you take to be the normative implications of this sort of phenomenological data?
Yeah, thanks. So that is an important point to guide and inform a prospective patient on their potential risk. So imagine that when they enroll these patients, most of these patients have read something in the news and was always positive. They meet their clinician, the clinicians, oh, we have this trial, would you like, but nobody get into the dimension of it might psychologically impact negatively someone, because even if it works, it will not generate great well-being. So it's a way to perceive it. So the phenomenology is central in articulating the normative or even prescriptive dimension of this trial, actually, because again, these are first in human. We're just starting to understand the impact of these devices on these degrees of what constitute a human and a patient. And yeah, it is in that respect that we must investigate further. And because when you read these clinical cases, there's little to no mention to the subjective experience of these patients, actually. Yeah.
Next question from Brennan. If you want, you can take directly the floor.
Hi, thanks, Susie. Hi, Fred. Sorry, I'll look. I've got two screens. I'll look to not be rude. Thanks very much for the talk. That was really interesting. I was wondering, do you think there might be different outcomes, and specifically, I'm thinking possibly less negative outcomes, if the intention going into these experiments was somewhat different? So obviously, a lot of this data is coming from an attempt to treat an affliction. But if I was, say, hypothetically going to take some deep brain stimulation in order just to enhance myself, and I didn't suffer from any sort of affliction, so I was a Tryborg, I guess.
Yeah,
what you previously
you would
said,
be a Tryborg.
that I might be like more or better positioned to accept that there's going to be some sort of change in my personality, something more fundamental, because I'm not just trying to treat my epilepsy, and then in addition to that, I have this, identity crisis going on as well, which wasn't part of what I was expecting. I just wondered maybe if we'd see some different results, or what your thoughts on that was.
Yeah, we published a paper called "The Burden of Abnormality," which is a continuity of the burden of normality. So we have seen that there are patients that were implanted with DBS for the Parkinson, but started to have capacities enhanced, like for instance, memories or sexual pleasure, etc. But we realized that it became a burden after a while. So even if you are trying to target a specific aspect of your personality, like enhance your memory, there will be a potentially, or I would say likely, a cost associated with this. And so we have tried to articulate that plausible scenario. And again, it's we have, so in the I Miss Being Me paper, we realized that all the patients that accept, I think Susie would talk about it, the phenomenology of the disease is one of your expertise. We have realized that when the patient accept their condition, they are perfectly fine with having Parkinson's disease, they were 100% unlikely to develop self-estrangement after the stimulation. So it's the role that disease plays in self-understanding is crucial in how post-operative understanding will play out. And but Sian, to be honest, we can only speculate about it because to my knowledge, we only have anecdotal cases of patient having some form of an enhanced abilities following the intervention. So, but I would be on the team that it is probably going to cause an abnormal side effect, and that would be psychologically difficult to bear. Yeah.
Fair enough. Thank you.
Thanks. Thank you.
Thank you so much. This is truly interesting, and the chat is on fire with questions. So I move forward, and there's Victor who would like to ask a question for you.
Hello, can you hear me? Okay.
Yes.
Thank you. Sweet. Awesome. Like super cool. Thank you for the talk. So I'm gonna try and word my question so it's not too convoluted. But I was curious, what are your thoughts on given this talk and the information you know about implants? What are your thoughts on like what are the parallels, if any, or the overlap with I'm sort of making a claim here, like social media, like addiction, and then also like substance abuse. Let's say like with Adderall.
Yep.
Let's say so like so with social media, like the serotonin you get from the affirmation you get from like getting likes or shares, blah blah blah, which is not actually substantial. It doesn't actually you know, if it's like a meme or something, if you're sharing a joke, there's and if you don't get like something that might negatively affect you, then also let's say I don't take Adderall, but I was watching we did an assignment where we had to watch a video on Adderall. The patients using Adderall, there was mixed feelings. So like some people, one person in the video particularly found Adderall really useful, but then the majority of people on Adderall didn't feel like themselves. So like they felt like their accomplishments were because of Adderall, and it didn't feel like they were doing it. It was the medicine.
Yeah.
Is that appropriate? Like, sorry.
I will try to answer with analogy with you mentioned addiction. So we have noticed with patient 6, again, she had a symbiotic interaction with the technology. So that means both sides get benefit, not only one side, so both sides, even the algorithm had benefit out of that relationship. Yeah. So with that symbiotic relationship, we realized that she became borderline addicted to the prediction. So she was over-reliant, over-dependent. And as such, she couldn't do anything without consulting the device. So then you back to these social media where people constantly back on the loop. So being in that decisional loop where you can't escape it, you need to consult prior making a decision because the system know better than you. Basically, this is why AI is a bit scary because it's transcends biology and your phenomenology or self-phenomenological understanding because the system can predict ahead and far better and accurately. So and as such, we have observed a borderline case of over-reliance, but in our case, it makes sense because you have epilepsy, but you can think about if that device is then applicable to other forms of pathology because it will. This is how they are treating now closed-loop device for depression, OCDs, Tourette. You can think about, even think more complexes with addictions. So so I think that there's parallel clearly, and certainly if there's a dopaminergic discharge associated with a right prediction, I think
Could I ask a quick follow-up? What would you suppose then? It sounds what would be the small quick differences? Like because
between the chemical one, you stop using the drug, that's it, right? But with the brain implant, most of them are irreversibly implanted and will damage your neuronal tissue to the point where you lose opportunity to get something in the future. And and also there's an organic penetration of the tissue, and that actually might compromise. There's reason some people say causing lesioning, and that might actually increase the impulsion.
Thank you. Thank you. Thank you very much. Sorry for the 2 questions. Thank you. I appreciate it.
Please, thanks.
Next question comes from Ian Stevens. The question is, how do we understand the phenomenological changes observed with the neurostimulation when compared to possibly similar phenomenological changes with the neurological psychiatric medications?
Well, that's a tough one. Thanks, Ian. Well, I guess if we are able to establish some proper qualitative tool that can capture these variation, then we'll be in a position to, I think, distinguish or make a contrast between those elements. Clearly, diseases like Parkinson's disease, which traditionally have been described as being a neurological disease, get more and more attention from a psychiatric perspective. Now we know that it's not only, the dopaminergic dysfunction do not only affect the neuronal system, it also affect the psychiatric, aspect of the brain. So, yeah, it's a tough one. I think if we can answer that question, we will obviously resolve all the regulatory issue with measuring this distinction between, if a depressive symptom is actually being caused by the stimulation rather than helping it, for instance. Yeah, thanks. I don't think I have an answer. Thank you very much for the question.
Thank you so much for this honest answer. Andrew asks, can you at least turn it off if it's permanently implanted?
Yeah. So you would be surprised. Many people keep the device in their brain, actually, because most of the time it's in biocompatible material, so it can last years, decades, without no problems. Yeah, you can turn it off. But again, even with it being turned off, there are cases of people suffering from hypomania, because again, it's a physical intrusion and penetration in the neuronal tissue, and you can think that it does lesion some area that can lead to some drastic outcome. Yeah, but yeah, short answer is yes, you can turn it off. Yeah.
Thank you so much. Anyone more questions? So we have 5 minutes less, more or less. This is truly interesting. My concern, I think it's ethical. We discussed a lot about psychological concerns, but we can foresee a future in which less and less people will be willing to take responsibility, which we are already on a good place. So it's going to be even worse. And we have somewhat a manufactured sense of normality. I mean, because if we say, okay, we do an implant to help with depression, okay, so what's the standard? What's the golden standard for normality?
Clearly, yeah. There's always a benefit. I mean, if everybody was happy always, I think it would be a terrible thing for society. We need people being a bit sad. That's why we have so great movies and books, and I think romance are based on that. But yeah, so you're right. So it will certainly dictate a specific normalcy, which might not be the most pleasant one, especially if someone is refractory to being implanted. And yeah, the observation. Oh yeah, something else I should have concluded is that their narratives seem to shift the blame on a device rather than their decision making. Although it seems that they were sort of forced. We use these. We can see that, and actually. So we have more with actual patients that are paralyzed, and we also have these narrative where they describe the system acting without their consent. So they animate prosthetic limb and what we call false positive, where they never intended to do that, but the harm did it. So this is still very ambiguous because, you know, now these things happen in the lab, but you can think in the future that it might cause compromise few elements. So who will be responsible? Is it the programmer? How can you demonstrate it that you didn't think of it? Or the burden might be on the patient. Or is it the manufacturer? It's quite novel. It's called in philosophy the responsibility gap. There's more and more work done into that, not necessarily with BCI, but in AI in general. It's quite interesting and changing field. And I mean, if anybody's interested, we're certainly happy to encourage your research into that.
I will certainly pass the word among my students. You will receive an email for sure. Here we have one last question from Liam. He asks, I wonder how many of the deleterious side effects mentioned were placebo as well.
How many? So I didn't. So how many? So I'm gonna.
Bad side effects.
No, yes, clarify that just a little bit, because you mentioned a lot of these things regard depression and feelings of losing control. So I wonder how many of these things were kind of just placebos from an existential anxiety that would be derived from grappling with one's sense of humanism, you know, in being part of a technical, or to have these technological implants. It might be like, oh, maybe I'm, you know, less human or whatever. So with this, you might have some existential anxiety that they may not have been prepared for, which could then lead to further depression, anxiety, and other things of that nature. So I wonder how many of these reported side effects were kind of a placebo and not necessarily caused from the implant itself, but how one kind of grapples with having the implant.
Yeah, thanks, Liam. This is a very interesting question because it touched the history, actually, of deep brain stimulation and brain-computer interface. So when we look at the first human, like 25 years ago, 30 years ago, implanted, many patients, actually some lady most of the time, had some aesthetic reaction. They felt like they were an electric doll. They felt like the RoboCop because they weren't used to have the device under the skin, the box here. But as we were seeing more and more patients implanted, now there's more than 200,000 patients implanted, we don't get this narrative anymore. It's becoming more and more in a way normal. I don't like that word, but so yeah, you don't have what you call the existential anxiety. I like that term. Thank you very much. And yeah, clearly, so yeah, this is slowly vanishing. So now we can see there's a bit more vivid cases. And just to conclude, the patient 3 that we have seen also had that narrative because yeah, she was young, still had this self-image construction, and having the device on her sort of Rupture her self-image. And there's a little bit of that into this element to where the symptoms were induced, despite the fact it was positively positive in terms of medicine. But yeah, thanks, Lem. It's a very interesting element. Yeah. Someone I have to read and write about that, actually. You want to get busy, you should write something about it, Liam.
Thank you so much. I don't see more questions coming up, and for you it's 2 in the morning now. So thank you for a wonderful presentation.
Well, thank you very much, everyone. Thanks, Susie, again for organizing the webinar. And if you have any questions, just drop me a line. Yeah.